Hello, and welcome to our webinar today entitled The Treatment of Women with Polycystic Ovary Syndrome. I'm Dan Dumesic, the Professor and Division Chief of Reproductive Endocrinology and Infertility at UCLA, and I welcome you to this webinar today. And for those interested, please join us in the conversation of PCOS by twittering #UCLAMDChat. Polycystic ovary syndrome is the most common reproductive disorder of young women. In 2005, it was estimated that in the United States alone, more than $4 billion was spent in either the evaluation or the treatment of polycystic ovary syndrome, which centered on menstrual dysfunction, infertility, diabetes, abnormal hair growth, and essentially not considering the risks of pregnancy complications and other costs involved with polycystic ovary syndrome. In 2003, the, quote, Rotterdam Consensus, unquote, came out with a diagnosis of polycystic ovary syndrome, which consisted of selecting either 2 out of the 3 abnormalities that you see on this slide. Number 1, either clinical or biochemical evidence of androgen overproduction, irregular menstruation due to a woman not ovulating, and the presence of polycystic ovaries that I'll share with you in just a moment. This was excluding other endocrine abnormalities that are rare in the population of young women, including various types of rare tumors, adrenal abnormalities, which also produce male hormone production, and other types of abnormalities that are rare and infrequent when we do testing for polycystic ovary syndrome. Using ultrasound imaging, the criteria for a polycystic ovary as compared to polycystic ovary syndrome is the presence of 12 or more follicles, each containing an egg that you can see on the slide in the upper right-hand corner, with either increased ovarian volume of greater than 10 milliliters, consistent with the presence of polycystic ovaries in the patient. Either 1 or 2 ovaries is sufficient to make the diagnosis. And these ultrasound images do not pertain to individuals using oral contraceptives because the ovaries are smaller on oral contraceptives. And in the event an individual has a cyst or a growing follicle from an ovulation, then of course you have to do the ultrasound in the absence of that cyst to get an appropriate measurement of the ovarian volume. With these criteria, you can see that there's essentially 3 phenotypes or types of polycystic ovary syndrome. The most severe form and the most common form in the United States is the presence of androgen excess and irregular ovulation. Most of those women also have polycystic ovaries as well, and this phenotype or type consists of about 75% of all women with polycystic ovary syndrome. It's important to recognize, however, that there's milder types of polycystic ovary syndrome. For example, androgen excess with polycystic ovaries, in the absence of any ovulatory dysfunction or anovulation, is a much more milder form. And perhaps the mildest form is the presence of polycystic ovaries and ovulatory dysfunction with a total absence of androgen excess. And this needs to be kept in mind when the diagnosis of polycystic ovary syndrome is made, because each individual represents a specific type of PCOS, which obviously has different implications for both reproductive and metabolic long-term health care. Now in the clinic, when we see women with polycystic ovary syndrome or possibly having this type of finding, we look for what's called the Fairman-Galloway score, or a clinical inspection of how we see the presence of coarse terminal hair on the patient, generally in a male-type pattern of distribution. This tends to be regions of the body which are central to the body, including the upper lip, the chin, the front of the chest between the breasts or the sternum, the lower and upper abdomen along the midline, the proximal or near aspects of the arms and legs, and finally the back along the middle of the back and the sacrum in the lower part of the abdomen. Using these criteria, there is a semi-quantitative scale that we can use to assess whether there's evidence of clinical hirsutism, or coarse terminal hair in a male distribution on physical examination. Of course, the scoring system is relatively crude because it does not factor in people's emotional aspects of what they feel about their hirsutism, nor does it look at all areas of the body that are tending to grow abnormal hair growth in response to elevated androgen levels. And maybe most importantly, it does not factor in ethnic groups, particularly individuals who come from ethnic groups of Mongolian races, largely the Asian population, Eskimos, Native Americans, tend not to have the same types of hair follicles nor the number, and therefore can have severe elevations of androgens and not necessarily have this present on physical examination. For this reason, we also fall back on blood testing to measure male hormones. It's important to recognize that when the doctors measure testosterone as the principal male hormone, that it's measured essentially in the early morning hour, in the early part of the menstrual cycle, and this is because testosterone levels change throughout the menstrual cycle, varying by almost 25% throughout the follicular phase or early part of the menstrual cycle, and have the highest levels in the morning due to changes throughout the day in circulating levels of testosterone. We can also measure free testosterone, which essentially represents the amount of testosterone that's biologically active. This calls for specific blood tests in specific laboratories that have assays developed to measure low amounts of free testosterone in a consistent and reproducible manner. Now, another source of male hormone production is actually the adrenal gland and not the ovary. And the adrenal gland, resting on top of the kidneys, is also capable of overproducing male hormones, generally through various types of genetic diseases or sometimes rare tumors. For this reason, we measure a hormone called 17-hydroxyprogesterone. This is a hormone that really reflects a type of genetic disease called late-onset congenital adrenal hyperplasia, which tends to be more frequent in certain populations of individuals. Individuals who are from an Ashkenazi Jewish background, Hispanic individuals, and those from either Yugoslavian or Mediterranean populations. Also, another male hormone that comes from the adrenal gland is another hormone that we call DHEAS, a very mild hormone in terms of its action. And though it's elevated in a small percentage of individuals who have normal testosterone levels, it generally is unlikely to affect the clinical care of the patient. So what is the treatment of hirsutism and these various abnormalities that bring the patients to come and see us? Hirsutism, as I mentioned before, is the presence of coarse terminal hair present in the body in a male pattern distribution. The first and foremost strategy is oral contraceptive therapy, because oral contraceptives suppress male hormone production from the ovary. In addition, we can combine oral contraceptives with other medicines that work specifically at the level of the skin to block androgen action, and these anti-androgenic medications, as they're known, consist of various types, including cyproterone acetate, which is not present in the United States for use, however used in other parts of the world, spironolactone, flutamide, and finasteride are all various type of medicines that are aimed at blocking androgen action to some degree at the level of the skin. Also, individuals can use medicines that try to inhibit the growth of the hair follicle. A medicine called eflornithine hydrochloride is one such medication. But ultimately, coarse terminal hair that's already present on the body essentially needs to be removed, because all of the medical therapies are aimed at slowing the growth of the hair follicle and making it. The commonly used therapies for local removal tend to be temporary cosmetic strategies, often used by patients before they see us, including bleaching, chemical agents, shaving, and waxing. However, any of these therapies are associated with mild or moderate forms of what we call folliculitis, irritation to the skin from plucking or removing the hair. As a result, there are other ways of doing it, which consist of either electrolysis, which is the local destruction of the hair follicle on an individual basis, or now the more common use of various types of lasers which can cover large areas of skin over relatively short periods of time, although they tend to be more expensive than some of the other therapies that I alluded to earlier. Now, as a reproductive endocrinologist, I see a lot of individuals who are having problems with infertility, and largely this is because individuals with PCOS don't ovulate on a regular basis, if at all. There are three principal hormones that have been linked with the inability to ovulate in women with PCOS. Number one, and perhaps the most important, is the elevated level of androgens and their metabolites in the ovary are capable of inhibiting the ability of the granulosa cells within the follicle that make estrogen and nurture the egg to proliferate and grow. Another possible mechanism is that these same granulosa cells normally make a hormone called anti-Mullerian hormone, which acts in the level of the ovary itself, and if made in excess, as it is in PCOS, also tends to inhibit follicular growth. And finally, insulin elevations, in part related to obesity or other factors, can arrest the growth of these granulosa cells and also inhibit growth of the follicle. And as I'll share with you in a moment, these are really the underpinnings of the mechanisms responsible that we address when we give people medicines to ovulate. So let me share with you now a principal mechanism that we understand as reproductive endocrinologists and trying to manipulate for purposes of ovulation. Under normal circumstances, the brain talks to the ovary, and the ovary communicates back to the brain in what we call a negative feedback inhibition system. In other words, the brain sends out hormones, one including follicle-stimulating hormone, to travel in the blood, to go to the ovary and make the follicles grow. As the follicles grow, they produce estrogen, which returns through the circulation to the brain to tell the brain the follicle has sufficient stimulation, and this clamps or suppresses FSH in a closed-loop system. As reproductive endocrinologists, we know that if we can push up FSH in the blood, we can drive the follicle to grow, and we can do that by either inhibiting estrogen production by blocking its synthesis through an enzyme called aromatase, or we can block the effects of estrogen on the brain by giving a medicine which is, quote, an anti-estrogen. Clomiphene citrate is an anti-estrogen which is commonly used as first-line therapy for ovulation induction in polycystic ovary syndrome. Metformin is a medicine called an insulin sensitizer which lowers insulin levels in the circulation and to some degree lowers androgen levels as well. Metformin does not differ from clomiphene regarding ovulation induction, pregnancy, live birth, or miscarriage rates. So we have some alternatives on which agent to use, one versus the other. Clomiphene citrate acts rapidly to block steroid negative feedback. But by blocking steroid negative feedback, the FSH can go up to drive the follicle, and sometimes more than one follicle can grow. As a result, clomiphene citrate is associated with approximately a 5 to 10% multiple birth rate, while metformin gradually reduces insulin levels and tends to be associated with a lower multiple birth rate. This means that the physician has some strategies as to how to use one medicine versus the other. Clomiphene, for example, might be preferred when time to conception is essential, often in women beyond the mid-30s, where essentially they're trying to get pregnant as soon as they possibly can. Metformin, particularly with lifestyle changes, is an option for those individuals where conception is not urgent, or perhaps if reduced multiparity or multiple birth rate is desired. For example, if somebody's had a history of a weakened cervix or damage to the uterus, in which multiple birth rate would be associated with an increased risk for premature labor. More recently, the ability to block aromatase, which makes estrogen, has also been a clever way to introduce ovulation protocols for women with PCOS by elevating FSH. These medicines go by the name of letrozole. or aromatase inhibitors. And there is some evidence that letrozole is more effective than Clomid for ovulation induction because its possible advantages are a lower incidence of multiple birth because hormone negative feedbacks are left intact, lower estrogen levels. This might be important in individuals who have estrogen-dependent diseases, history of blood clots in the legs, history of breast cancer with estrogen receptor positive markers. And also, letrozole does not necessarily have the anti-estrogenic effect on the uterine cavity, the lining, which also is a side effect in some individuals taking clomiphene citrate. So aromatase inhibitors might also be a third option available for people with ovulation disturbances in PCOS. Now, what's the second line therapy if clomiphene or metformin or letrozole don't work? They consist of two strategies: low-dose gonadotropin therapy, which consists of administering FSH, which is available. This bypasses all the system and goes directly to the ovary with a hugely successful ovulation rate of 70%, most of which are one follicle. But the pregnancy rates over time can average about 15 to 20% per month. Over 4 to 6 months, a 72% cumulative pregnancy rate, which is good. But here again, a risk of multiple birth and a small but worrisome risk of severe hyperstimulation syndrome, where the ovaries get so large they in fact throw off fluid and electrolyte balances in the body. Fortunately, with modern monitoring, these risks for stimulation in a severe form are under 1%. One can also do laparoscopic ovarian drilling. This is a procedure that's not as commonly used in this country as other countries, but really resorts to the idea that if one can look at the ovary directly and put an instrument into the ovary, into the middle where the androgen production originates from, then if that could be destroyed through some sort of thermal energy, then you will lower the testosterone levels and ovulation will occur. This does work with an overall pregnancy rate of about 58%. However, it takes time for this to occur, up to 2 years. Severe adhesions can be formed in some individuals, and if the drilling procedure is overly aggressive, in fact, you can damage the ovary, leading it to its failure. Now, it's interesting that we haven't really mentioned obesity at all in the definition of polycystic ovary syndrome. So what is the role of obesity and polycystic ovary syndrome? There's an interaction between these two abnormalities where obesity influences the PCOS phenotype by unmasking the symptoms of androgen excess in susceptible individuals. Let me be specific on this. All individuals gain weight around their abdomen as they gain weight through an increase in body mass index, which is an estimate of one's weight versus one's height. But individuals with polycystic ovary syndrome have a propensity to put on weight around their abdomen. Those so-called the apple versus the pear body fat distribution. This is important because central adiposity around the abdomen is associated with a feature called metabolic syndrome, which is the constellation of abnormal abdominal fat, hypertension, elevated glucose levels, and abnormalities of lipid levels, particularly high-density lipoprotein suppression and elevation of triglycerides. For this reason, individuals coming in with a possible diagnosis of polycystic ovary syndrome should undergo some basic physical examination features: blood pressure checks to rule out hypertension greater than 130 over 85 millimeters of mercury. They should be weighed to determine their body mass index with 25 to 30 kilograms per meter squared, representing overweight, and over than 30 kilograms per meter squared, representing obese. In the United States, that represents 2/3 of our population. Finally, abdominal circumference by measuring the girth of the abdomen at the top of the hips or the iliac crest that you can feel on physical examination. In most individuals who are Caucasian or African American, that should be under 88 centimeters or less than 35 inches. And in certain individuals, again referring back to individuals of the Mongolian ethnicity, those numbers are reduced to compensate for those factors so that the range there should be under 80 centimeters or less than 31.5 inches. Quality of life assessment needs to be addressed because women with polycystic ovary syndrome have a higher incidence of what we call mood-affective disorders associated with depression, and depression and these disorders are now associated with independent risk factor for cardiovascular disease. Finally, a 2-hour oral glucose tolerance test to rule out prediabetes or diabetes, and a fasting lipid profile that looks at the various types of lipoproteins, including total cholesterol, high-density lipoprotein, low-density lipoprotein, and triglycerides. Now, I wanted to share with you that recently guidelines for the treatment of obesity have been put out into the professional community. This refers to all individuals and not just individuals with polycystic ovary syndrome. In those individuals who are overweight with a BMI of greater than 25 kilograms per meter squared, lifestyle intervention consisting of diet and exercise is the #1 strategy. In those individuals who have a BMI over 30 kilograms per meter squared, or even less, as low as 27 kilograms per meter squared, if there's a comorbidity, such as prediabetes, then medications have been newly developed to look at these managements of trying to bring down body weight in individuals. And finally, third-tier therapy, if the body mass index is over 40 kilograms per meter squared, or perhaps less to a range of 35 kilograms per meter squared with a comorbidity of hypertension or diabetes, then bariatric surgery might be an indication. Now, I don't want to get into a great deal about the mechanisms of action of some of these new weight loss medications, but I'd like to basically state that they're all focused on managing what we call satiety or appetite, and so they act at the level of the brain. The ones that are out that have been released and may be released in the future are lorcaserin, phentermine combined with topiramate, and perhaps bupropion and naltrexone. I just want to mention that if you look at the weight loss success rates, you see that compared to placebo, where the weight loss is only about 2 to 3% over 6 months, some of these medicines are associated with anywhere from a 6 to 11% drop in weight loss, which is really quite significant compared to what people can often do on their own. Now, each one of these medicines has its own side effects and concerns. It's important for people not to get pregnant during this time, so that puts a challenge to us as infertility specialists, particularly with one of them associated with birth defects, including cleft lip. So the timing of these managements have to be carefully matched to the desires of the patient, particularly in the realm of fertility, where many of these people might actually be older. A bariatric surgery is also a very, very aggressive but highly successful management in the treatment of obese women with polycystic ovary syndrome. The original studies performed in 12 people with severe PCOS basically showed that after approximately 1 year, the weight loss was 41 kilograms, which was a very large amount of weight loss. And if you look at the reproductive abnormalities in these individuals, their hirsutism score diminished, their total and free testosterone levels diminished, their androstenedione, which is another male hormone in the body, and their DHEAS, the adrenal gland male hormone, diminished, and HOMA, which is a measure of insulin resistance, also improved to such a degree that virtually all 12 of these people lost their PCOS phenotype entirely. When you look at the data that look at the metabolic aspects of PCOS and how that improved by bariatric surgery in those PCOS women who were obese, you can see by looking at the right side of the screen that 100% of these individuals improved in their diabetes, their dyslipidemia, meaning their abnormal lipid levels, improved in most of those people, including improvement in their hirsutism, 100% improvement in their menstrual abnormalities to such a degree that normal menses occurred within 3 to 4 months after the surgery, with all 5 women in this study who wished to conceive doing so without the use of clomiphene citrate or any other ovulation induction medication. Of course, these women therefore needed less medications as well. Now this brings up a double-edged sword, because in individuals who undergo bariatric surgery, their profound weight loss is associated with tremendous shifts in their metabolism, including the potential for the loss of critical fat-soluble vitamins. So it is recommended that surgery should be performed, and then conception should be delayed 1 full year until we know that the nutritional status of the woman is appropriate to sustain a normal pregnancy. And this is an important feature, again, dealing with individuals who are in their latter part of their 30s who are trying to balance conception ultimately with adequate health. Now, I'd like to just mention one controversy, because I think it's important for everybody to recognize who's listening, including physicians as well, and that is the diagnosis of the polycystic ovary by ultrasound criteria, when it was developed several years ago, did not factor in the age of the woman. And that is a crucial bit of information, because not surprisingly, if you look at normal women going through puberty, particularly within the first 6 months of their menses, 51% of them have menstrual irregularity, as you would guess. Very few of them have clinical hirsutism, because it takes time for that to occur. And 35% of women, of those young women, had polycystic ovaries using an abdominal ultrasound, which is not even as precise. This tells us that if you use the criteria we normally stand by, you're going to overdiagnose the polycystic ovary, and you're going to underdiagnose clinical hirsutism because there's insufficient time. That's why the current recommendations, although imperfect, have recommended that in adolescent girls, all 3 elements of the Rotterdam criteria should be used to diagnose polycystic ovary syndrome. Biochemical tests rather than clinical hirsutism should be used, because you can measure the blood and you don't necessarily see the hirsutism on exam. And finally, you should wait at least 2 years after puberty begins or menses begins to let people establish their normal menstrual pattern or not. And then polycystic ovaries should perhaps better be defined by their size rather than the follicle number, which is going to be high in individuals who are young. You see this in the current recommendations of reproductive age women trying to have a constant definition of the polycystic ovary. In this particular study, it's a compilation of a number of endpoints to say what's the best way of diagnosing polycystic ovary in a reproductive age woman. Is it antral follicle count? Well, I mentioned earlier in this talk it was 12. Maybe it should be 19, because the machines have gotten better and more sophisticated, so the number that we're counting is going up. Maybe it should be a measure of anti-Mullerian hormone, the hormone I mentioned earlier in the talk. But what cutoff level do you use? Should you use 35? Should you use 48? These are controversies. And finally, the volume. How should we factor that in? These are areas of discussion that are currently going on in the literature. And finally, as you see women age from puberty to reproductive life to late reproductive life, you see for every decade that they age, they have a lower number of follicles in the ovary, exactly what you would guess. And as follicle numbers decrease, so does testosterone, because that is a feature of the follicles and the tissue in the ovary. And as the testosterone drops as women age, not surprisingly, the phenotype improves. So in young women, the chance of having a severe phenotype, what we call NIH criteria, is 80%. By the time a woman is in her 30s, the incidence of the severe phenotype has dropped down to 72%, and the mild form is increased to 17%. This tells me as a physician and others, be very careful on labeling somebody with a finding if that finding, particularly a morphological finding, is a moving target. For this reason, we are interested in looking at several aspects of reproduction and metabolism in polycystic ovary syndrome. At UCLA, we're doing a clinical trial that's funded by the National Institute of Health, where our hypothesis is that androgen excess in lean PCOS women alters fat metabolism and impairs ovarian function. Essentially what we're measuring body fat distribution, content, and function in lean PCOS women compared to lean normal women without PCOS. And this is because we want to remove the obesity question from the entity so we can understand the pure form of polycystic ovary syndrome. We are then going to examine whether oral anti-androgen therapy corrects the metabolic and reproductive dysfunction of lean PCOS women. And if you wish to learn more about this study, please email UCLA OBGYN research at mednet.ucla.edu or call 310-825-5255. Thank you for your attention. Please join the conversation if you wish by going on hashtag UCLAMDChat or MDChat, and I'm happy to answer some questions that have already been sent in. Okay, so a number of questions have actually been sent in, and the first question is, how can your doctor determine which type of PCOS you have? It's very simple, and it's very cost effective to do this. A physical examination with the measures that I talked about before on blood pressure, weight, height to figure out body mass index, abdominal circumference, and a quick assessment of what I mentioned before, the Fairman-Galloway score. That will be able to at least give you an immediate assessment of what's going on. And with a menstrual history, menses should occur between 21 and 35 days duration. If they fall outside of that realm, there's either irregular ovulation and no ovulation. By then measuring androgen levels in the blood and ruling out some of the rare forms of ovulatory dysfunction, including elevations of prolactin, looking at some aspects of the adrenal androgens, if the person's from a certain ethnic group that I mentioned, can easily determine what's going on. The presence of polycystic ovaries is the third feature that can be done, but even if an individual physician is not doing ultrasounds, using some biochemical criteria can certainly categorize the individual as to where they are in the spectrum of polycystic ovary syndrome. If I have PCOS, can I get pregnant? Absolutely. The trick is, how can we make sure that monoovulation occurs, which is essentially one follicle, to limit the multiple birth rate? The time now in this year is particularly interesting to us because we have so many medical options available. And with proper surveillance, conception is relatively straightforward by ovulation induction. But also remember that 30% of infertile couples have more than one factor. So if there's another disease present, male factor infertility, tubal damage, of course, the management may change appropriately. Can I get pregnant without drugs if I have polycystic ovary syndrome? It depends. If a woman is overweight, studies performed several years ago showed that if an individual could lose 7% of their body weight, many of those individuals resume ovulation spontaneously and can conceive. So the presence of PCOS with increased adiposity, one can use lifestyle modification to avoid the medications as long as somebody's aggressive about it and is willing to take the time to do it. If an individual is lean and not ovulating with PCOS, then medications will probably be necessary. Why is PCOS stressful? PCOS is stressful for a number of reasons. First and foremost, there's a body image aspect in some individuals that's particularly troublesome to them. This is one of the reasons why we want to do quality of life assessment on these people to understand what is their self-image and why do they feel their image is not what they want it to be, if that's truly the case. Other individuals are very aware that their metabolic derangements, including their lipid abnormalities and their sugar metabolism problems, are a direct threat to their well-being because they increase the risk of cardiovascular disease. So there's a number of reasons that people really come to us with issues of image perception that center around their psyche as well as their own health. How accurate are tests for polycystic ovary syndrome? They're very accurate if you recognize that even women with polycystic ovary syndrome who have elevations of androgen levels in their blood, those androgen levels are lower than those normally found in a male. The testosterone assays are very good at measuring male hormone levels, but not necessarily the lower levels found in women who are normal or who have PCOS. Therefore, the tests have to be or should be performed in particular laboratories that do an extraction step of this blood to remove contaminants, and then either use sophisticated assays or what we call tandem mass spectrometry to get a good read of those absolute levels, because we're going to make big decisions on those levels. But they are accurate if properly performed. Why can acne be a warning sign of polycystic ovary syndrome? The reason why acne is a warning sign is because the hair follicle also has a sebaceous gland associated with it. Sweat and sebum can block the sweat gland, and bacteria can enter into the sweat gland and cause acne. That can occur faster than the growth of a hair follicle, which tends to have a turnover rate on the face of about 4 months. So acne can be a prodromal feature or an early feature of polycystic ovary syndrome. The problem, there's no uniform way of measuring it. So again, as a symptom combined with other laboratory data, one can distinguish acne that is not related to PCOS from acne that might be a symptom of PCOS. How can PCOS cause endometrial cancer? There's really a very well-known mechanism, and then there's a second mechanism that people are starting to study more recently. If women do not ovulate, they do not make a hormone called progesterone, which is intended to clean out the lining of the uterus every month with menses. In the absence of ovulation, estrogen is produced. The endometrium, or the lining of the uterus, proliferates and continues to grow. Progesterone is never made so that there's no stop signal to the endometrium to grow. And over many, many years, one will experience long-term irregular bleeding and ultimately an increased risk of endometrial carcinoma, which is originating from this endometrium that's constantly been growing over long term without any mechanism to really stop its growth or slough. That's really the common mechanism that's been associated with endometrial carcinoma and polycystic ovary syndrome for many, many years. Now there's been an interest in insulin, because insulin is also a hormone that causes cell proliferation. And this might be the link between not only PCOS, but other types of obesity that are not associated with PCOS and also associated with elevated insulin and increased risks of endometrial carcinoma. What are natural treatments for polycystic ovary syndrome? As I mentioned before, the natural treatments fall into what you can do with your lifestyle, and I assume this question is really focusing on other types of therapies that are non-medical. The current recommendation for people with lifestyle modification is, if somebody's overweight, to have a balanced diet that has a deficit of about 500 kilocalories per day, associated with 150 minutes of exercise per week as a minimum. The reason why exercise is important as an independent variable is that exercise makes muscle mass, muscle burns up sugar, so that individuals can actually maintain a weight and still improve their sugar metabolism just by the sheer increase in muscle mass alone. Finally, some people have been using some natural herbs to try and treat polycystic ovary syndrome. There's no clear evidence that any one of them is a standout compared to any other, and at least with the formulations we use in the clinic for medical management, they tend to be more standardized and probably more reproducible. How can I become pregnant if I have polycystic ovary syndrome? I think we talked a little bit about that before in terms of ovulation induction and also weight loss if increased weight is associated with polycystic ovary syndrome. What increases my risk for polycystic ovary syndrome? That's really an excellent question. There's now a lot of evidence that polycystic ovary syndrome is in part a genetic disease. And it's interesting that if polycystic ovary syndrome is a bad thing, presumably, in today's healthcare, and yet it's a very prevalent disease, the most common in reproductive age women, well, why is it still around? And this brings up the idea of the thrifty phenotype, the idea that the genes that predispose to polycystic ovary syndrome aren't necessarily bad at all. But many years ago, when there was not the availability to have food at such a regular basis, these types of genes program the body to hold on to fat and maintain it for times of starvation. So essentially, the genes that hardwire people for polycystic ovary syndrome are particularly good in the ability to store fat for long-term health care in times of famine and scarce food supplies. Now in today's environment where food is available, then these genes can actually work against us and predispose to fat storage, and might be one of the reasons why weight loss is particularly difficult in women with PCOS. That's why I showed the slide earlier that obesity in today's society, it really exaggerates the disease in people who have a susceptibility factor, which is based on a genetic basis. And there are family kindreds where the children have PCOS, and there's a high incidence of diabetes and heart disease and cardiovascular disease in the parents and in the generations before. This gets into some of the last questions. What causes PCOS? I think I just briefly talked about that. But then when does PCOS begin in life? Currently, as physicians, the earliest we can detect it is approximately 2 years after the onset of menarche or menses, because we need to have time for the normal menstrual cycles of women to straighten out or not. There is evidence, however, that even in utero, there's a potential risk for acquiring polycystic ovary syndrome, since some evidence suggests that male hormones are elevated in utero in female fetuses of mothers who have polycystic ovary syndrome, and therefore the idea of developmental programming, the idea of making sure the mother has optimal care during pregnancy to try and maximize not only the birth weight of the offspring, but that offspring's health throughout their own life is important and very popular to look at today on a research level. Should I keep going with some other questions? It looks like we have a few more minutes. How does androgen excess harm a woman with PCOS? Well, our current theory is that in addition to its ability to block the ovulation in the woman, it also tends to affect the way the signals of the brain are released to drive the ovary in terms of follicle growth. So there's a direct action in the ovary, there's a direct action in the hypothalamus and the pituitary gland of the brain. There's also some evidence that androgen affects body fat distribution, similarly to women with PCOS compared to men who both have characteristic abdominal adiposity, which is a risk factor for cardiovascular disease. So the androgen excess appears to have an adverse effect both on reproductive and metabolic systems. Do symptoms of PCOS change throughout life, and do signs of PCOS differ among various ethnic groups? That's a combined question. You can see from the slide I showed before, yes, things do change with life, because as women with PCOS age, they tend to shift from a reproductive problem because their follicle numbers diminish, their testosterone levels diminish, and therefore they tend to begin ovulating in their late 30s and 40s. But at the same time, the shift in their disease is moving towards a metabolic problem because our population is age. So what happens with women with polycystic ovary syndrome in younger parts of their life, they tend to have infertility, they have reproductive problems. Once they have their family, that tends to normalize, and then as time goes by, they run the risk of increased cardiovascular disease. So the phenotype does shift from reproductive to metabolic as a woman ages. Finally, the ethnic groups that are important, as I mentioned before, the Asian population or the groups of individuals of ethnic groups from Mongolian races, you really don't see the clinical manifestations too much. They don't necessarily present with hirsutism or acne, but they do have an increased risk of the metabolic abnormalities, and the doctor has to be careful of looking for those, otherwise they might be lulled into a sense of false confidence that everything's okay because the patient just seems to look okay. With that being said, I think we've covered the questions on the iPad that I just discussed, and I'd like to just thank everybody for being a part of this. This webinar is being recorded and is available on demand on our website. And again, thank you for everybody's participation.